Hi, my name is Chinyere Ogbonna, and I'm a board-certified physician in family medicine, psychiatry, and addiction medicine. I currently practice psychiatry and addiction medicine in San Jose, California. I'd like to talk to you today about how to approach a conversation about benzodiazepine tapering. It has been estimated that benzodiazepines are prescribed to 10% of the United States population, with primary care providers as a group accounting for about half of all visits where benzodiazepines are prescribed. Patient characteristics associated with long-term use of benzodiazepines include psychiatric and physical comorbidities, avoidant coping behaviors, and older age. As with any prescription medication, there are risks and benefits associated with long-term use of benzodiazepines. Risks of long-term benzodiazepine use include physical dependence, withdrawal, cognitive impairment, and in older patients, falls and fractures. Healthcare providers should be aware of these risks and should be able to communicate these risks effectively to patients, emphasizing the importance of patient safety. So let's start with a case. One of your medical colleagues has retired, and you're seeing one of their longtime patients in clinic this afternoon. Mr. Smith is a 67-year-old man with a history of hypertension, chronic low back pain, anxiety, and insomnia. He has been on long-term opioid therapy for chronic pain for the past 10 years. His dose has been stable, and he reports improved functioning since being maintained on Norco 10 milligrams, one tablet twice a day. About 5 years ago, he started to experience worsening symptoms of anxiety and sleep disturbance. After reviewing medication options with his doctor, the patient was started on an SSRI for anxiety and lorazepam for sleep. The initial treatment plan, as documented, was a brief course of lorazepam. However, the patient's dose has gradually increased from 0.5 milligrams at bedtime to 2 milligrams at bedtime. The patient also self-discontinued the SSRI after 2 weeks because it wasn't working. There have been no other medication trials for anxiety management, and the patient presents today to establish care and refill his medications. He's anxious and somewhat wary about meeting a new doctor. How would you approach this patient encounter? For many providers, this is a common scenario, an inherited patient establishing care with a new provider. While these visits may be daunting, it's important to remember that the patient likely has some anxiety about this initial visit, as they were used to seeing the same provider for years. Change can be hard, so maintaining an empathetic frame and leading with curiosity can help facilitate patient-centered conversations. An important first step in addressing this patient's case would be to do a risk-benefit analysis prior to the visit. According to the Joint Clinical Practice Guideline on benzodiazepine tapering, tapering should be considered when the risks of continued prescribing outweigh the benefits. This risk and benefit analysis is a continuous process and may be dynamic based on the individual patient's medical, psychiatric, and medication profile. Potential risks of continued benzodiazepine use include oversedation, memory and cognitive impacts, medical safety concerns regarding medication interactions, impacts on mental and physical health conditions, and disrupted sleep patterns. These risks should be weighed against potential risks of tapering and may include withdrawal symptoms, recurrence of the condition for which the benzodiazepine was initially prescribed, and impacts on mental and physical health conditions. The potential benefits of continued use should also be considered, such as functional and quality of life improvements and effectiveness in addressing mental and physical health conditions. Potential scenarios where the risks of continued use outweigh the benefits may include patients who are taking multiple benzodiazepines, are co-prescribed opioids or amphetamines, or are on supertherapeutic doses of benzodiazepines. Patients who have cognitive disorder or history of traumatic brain injury, patients who have a current or past history of substance use disorder, especially sedative hypnotic or alcohol use disorder, and patients who are older than 65 due to increased risks of injuries from falls and other cognitive adverse effects. When initiating a conversation about safety concerns related to long-term benzodiazepine use, motivational interviewing strategies can be helpful in setting a collaborative frame for the visit. The spirit of motivational interviewing emphasizes the importance of developing a collaborative therapeutic relationship, adopting a non-confrontational and non-judgmental approach, and guiding the patient towards change. For the busy clinician, motivational interviewing strategies have been shown to be effective for stimulating a patient's desire to change, even with brief encounters. The OARS acronym can be used as a guide for navigating these conversations. O stands for open-ended questions. Try to avoid asking yes or no questions. Open-ended questions allow patients freedom to respond without fear of there being a right or wrong answer and gives the provider an opportunity to learn more about what the patient cares about. A stands for affirmations. Find opportunities during the conversation to express empathy and celebrate the patient's accomplishments. Highlight and affirm the patient's strengths and efforts to change or maintain healthy behaviors. R stands for reflective listening. Let the patient express their thoughts and use reflective statements. This involves rephrasing the patient's words to capture the implicit meaning and feeling behind their statements. Reflections can also help encourage personal exploration and help patients understand their motivations more fully. S stands for summarize. Summarizing the discussion allows for checkpoints and also ensures mutual understanding of the discussion thus far. This can also help demonstrate listening and understanding the patient's perspective. Summarizing can also be an opportunity to point out discrepancies between the patient's current situation and their future goals. Another helpful framework for guiding these discussions is the three-component model for motivational interviewing by Renisau and McMaster. This framework was adapted from models previously proposed by Rolnick and Miller. The three tasks are exploring, guiding, and choosing. With exploring, the goal is to elicit the patient's story, build rapport, and obtain a behavioral history that includes prior attempts to change. Once that rapport has been established, the discussion can move on to guiding. This would be guiding the patient towards the possibility of change. This would also be a good time to share the risk-benefit analysis and safety concerns guiding your treatment recommendation. Choosing involves collaborating with the patient to build an action plan, anticipate barriers, and agreeing on a plan for monitoring. Although this three-task model implies a temporal sequence of explore, guide, choose, not all patients will follow this linear order. Some patients may be fully motivated to change, and they may benefit from starting with the choosing task earlier on, whereas others may require cycling through exploring and guiding before they are open to change. So how can we apply these tasks to the patient's case? During the initial visit, we can explore with the patient by focusing on developing rapport and gaining a better understanding of the patient's experience on this medication over the years, including why the patient was prescribed benzodiazepines in the first place. Approaching this conversation with curiosity and using open-ended questions invites the patient to share their experience starting the medication, reflect on their thoughts about the efficacy of the medication over time, and elicit whether they have had any adverse effects associated with being on this medication or any concerns about long-term effects of remaining on the medication. Initiating this conversation can also open the door to discussing any past trials with alternative medications to address the underlying symptoms resulting in benzodiazepine prescribing and what the patient recalls about any risk-benefit conversations prior to the initiation of this medication. We can then move on to guiding by asking the patient's permission to share your risk-benefit analysis and provide updated information and patient resources about the risks associated with long-term benzodiazepine use. The provider can elicit change talk by asking the patient what they think it would be like to make a small change to their dose and building discrepancy between the risks of continued prescribing without a change and the patient's broader life goals and values. Patients who have been on long-term benzodiazepines oftentimes will say, I've been on this medication for years, nothing bad has happened to me, so why do I need to taper? Or they may say, I take my medication as prescribed. I feel like you're treating me like I'm an addict. Providers should seek to understand the patient's perspective, thoughts, and feelings about tapering without judgment. Providing space for patients to openly discuss their potential fears and normalizing those fears can open up respectful exchange for patients who have been on benzodiazepine for years. It may also be helpful for them to know that the risk-benefit analysis may change as the taper proceeds. The goal of tapering may not be to completely discontinue the medication for some patients. Getting a patient to a lower dose may be sufficient to reduce the current risks such that they no longer outweigh the benefits. The next task would be choosing. During this task, the provider can identify a goal of a small dose reduction as an initial step. I found that providing anticipatory guidance for patients on what to expect with tapering can significantly reduce patient anxiety about medication changes. Providers can also review a general roadmap for tapering, but also inform the patient that there can be flexibility based on their feedback during the taper process. An example would be to start off by reducing the patient's dose by 5 to 10% every 2 weeks, with the option of pausing at a lower dose for a longer duration of time based on the patient's response and tolerability of taper. Collaborating on a general taper plan oftentimes will reduce patient anxiety and allow for some patient autonomy in discussing when to take the next taper steps. An example may be a patient may prefer to pause their taper around holidays or other stressful life events. This may also be a good time to discuss alternative behavioral interventions and medications to address underlying symptoms preceding the initiation of benzodiazepines and strategies for managing potential withdrawal symptoms. Part of the spirit of motivational interviewing is being able to roll with resistance. Reluctance to taper may take many forms, but oftentimes presents as interrupting and/or arguing with the provider, discounting the provider's expertise, being pessimistic about their chances of success with making a change, or insisting on not following along with treatment recommendations. Rolling with reluctance involves maintaining a non-confrontational and non-judgmental frame and understanding that the patient's response is likely rooted in anxiety or fear about making a change. If risks of continued prescribing outweigh the benefits, the provider should clearly communicate the risks and emphasize patient safety as a priority. Providers should acknowledge that the patient may hold a different perspective and remain firm in communicating patient safety as being paramount. Persistence in highlighting the shared goal of ensuring safe medication prescribing and allowing time for the patient to process upcoming changes may help guide the patient towards shared decision-making, moving towards the best path forward. So let's wrap up with some key takeaways. It's important to review the patient's medical, psychiatric, and medication history ahead of time to complete a risk-benefit analysis for continued benzodiazepine prescribing. It is also important to make time for conversations before making any changes. Depending on the provider's practice setting, it may be beneficial to plan for an extended visit by combining 2 patient slots, which will allow additional time to initiate a conversation about tapering. It may also be helpful to plan for another follow-up visit prior to making any medication changes to allow time for the patient to process the initial conversation and feel engaged in shared decision-making. Another tip would be utilizing motivational interviewing techniques to initiate the discussion about tapering. Change can be hard, so maintaining an empathetic frame and leading with curiosity can help facilitate patient-centered conversations. Acknowledging the patient's fears and normalizing them, rolling with reluctance, and providing anticipatory guidance can be helpful in reducing patient anxiety. Patient safety is paramount, so if risks outweigh the benefits, patient safety must be a priority, and providers should remain empathetic yet firm in communicating those risks to the patient. It's important to be persistent in guiding the patient towards the best path forward. Thank you for taking the time to watch this video, and I hope you find these tips to be helpful. For additional information on tapering benzodiazepines, check out ASAM's other microlearning videos and webinars in the ASAM e-Learning Center.